Welcome to this explainer. Today, we're taking the incredibly data-dense ACG 2026 guidelines and translating them into a highly actionable, step-by-step clinical playbook for managing hepatic encephalopathy. Whether you're seeing patients in a busy hepatology clinic, the ED, or the intensive care unit, having a structured, evidence-based approach is absolutely essential. So we're breaking down these latest guidelines from the American College of Gastroenterology into a practical roadmap, focusing heavily on a comprehensive clinical approach, literally from the moment you make the diagnosis all the way through long-term management.
But before we get into the clinical pathways, we really have to acknowledge the human stakes here. The guidelines highlight a profound truth. HE progression isn't fully captured by current transplant criteria, and this leaves so many patients in a devastating state of limbo. They're suffering from severe impairments to their quality of life, placing a massive burden on their families and caregivers. Yet their objective scores might not actually prioritize them for life-saving liver transplant. Keeping this human element front and center is absolutely crucial as we approach their clinical care.
All right, let's look at our roadmap. We're going to cover 1. The hepatic encephalopathy burden, 2. Clinical history and examination, 3. Diagnosing cognitive decline, 4. Inpatient evidence-based management, and 5. Outpatient care and prevention. Starting with Section 1, the hepatic encephalopathy burden, or the roller coaster of cognitive decline.
Patients with cirrhosis don't just sit at a steady baseline. They're on a highly unpredictable trajectory, constantly bouncing between covert HE, where they might just seem a little fatigued or maybe have trouble navigating their car, and devastating overt episodes that land them in the hospital. Because this decline is totally nonlinear, reliable clinical detection by you, the provider, at every single touch point is crucial. You have to catch them before they plummet into a grade 3 or 4 crisis.
Moving into Section 2, clinical history and examination, identifying those red flags. When a patient presents with cognitive decline, your history and physical exam have to be incredibly meticulous. You honestly cannot rely solely on a cognitively impaired patient for the history. You must actively interview their family members and caregivers. You're specifically asking about sleep-wake cycle inversion, recent short-term memory lapses, or new medication non-adherence. Then run down the checklist of common triggers. Ask yourself, why did this stable patient suddenly become confused today? On your physical exam, you are actively hunting for clues. Check for asterixis, that classic flapping tremor, and assess deep tendon reflexes for hyperreflexia. You also have to explicitly evaluate for spontaneous bacterial peritonitis, or SBP, by checking for abdominal tenderness, because that is a massive, often completely silent trigger. Identifying and treating these factors is just as important as starting HA-specific therapies. Think about it. If you miss a urinary tract infection, a subtle GI bleed, or SBP, all the lactulose in the world is not going to fix the underlying problem.
And it's not just about triggers, it's about mimics. There's a sheer volume of comorbidities that can perfectly masquerade as HE, which demands a highly disciplined differential diagnosis. You need to conduct a rigorous medication reconciliation. Hunt down any recently prescribed benzodiazepines or opiates. Dig into their alcohol use history. Could this actually be Wernicke's encephalopathy or alcohol withdrawal? And pay close attention to focal neurological deficits on your exam. Cirrhotic patients are at a really high risk for falls and coagulopathy, meaning a simple bump on the head could be a subdural hematoma mimicking HE. From sepsis to uremic encephalopathy, you have to systematically rule these out before anchoring purely on a diagnosis of hepatic encephalopathy.
Section 3. Diagnosing cognitive decline using testing and theragnostics.
Once you've taken that meticulous history, done the exam, and ruled out acute mimicking precipitants, it's time to formally assess the patient's cognitive domains. The ACG actually suggests a single test strategy over complex, time-consuming combinations. First, you have the QuickStroop app. It's a shortened version of EncephALAP that measures psychomotor speed and is highly predictive of future overt HE episodes. Just remember, you can't use it for colorblind patients. Alternatively, you can use the animal naming test. You just ask the patient to name as many animals as they can in 1 minute. It requires zero tech, it's incredibly easy to apply right in the exam room, and if they name fewer than the threshold, it strongly correlates with cognitive impairment.
But what if your clinic tests are borderline, yet the family insists the patient is struggling to concentrate or drive? The guidelines introduce this brilliant strategy, taking a diagnostic test drive using the theragnostic approach. This is basically a limited 4 to 8 week trial of lactulose. If the patient's symptoms reverse and their cognition clears up, well, that clinical improvement serves as your proof of concept that they had covert HE all along. Now, the absolute most critical step here is setting clear a priori symptom goals with the patient and caregiver.
You need to know exactly what improvement looks like to prevent them from just staying on endless unmeasured laxatives forever.
Section 4. Inpatient Evidence-Based Management. This is the acute playbook.
When a patient slips into severe, overt HE, your absolute first priority is safety and stabilization. Step 1 is assessing severity using the West Haven criteria and the Glasgow Coma Scale. If a patient is grade 3 or 4, your immediate priority is securing the airway. Why? Because these patients lose their gag reflex, and aspiration pneumonia carries a massive mortality rate in cirrhotic patients. You should really be considering immediate MICU transfer. Step 2 is that rigorous search for precipitants, exactly as we just covered in the clinical exam. Finally, Step 3 is initiating HE-targeted therapy. You literally cannot skip straight to Step 3 without ensuring the airway is safe and ruling out a massive bleed first.
When it comes to the actual therapies, the guidelines give us a very clear, authoritative hierarchy based on grade certainty. There is a strong recommendation with moderate certainty of evidence for using lactulose to improve patient outcomes and treat the acute overt HE episode. On the flip side, treatments like adding rifaximin to lactulose or utilizing a high-volume polyethylene glycol prep as an alternative are listed as conditional recommendations. They are excellent tools for your clinical arsenal for sure, but using them depends entirely on the specific clinical scenario, patient compliance, and how they actually respond to that initial lactulose therapy. Now, I want you to pay close attention to two major clinical pitfalls the ACG explicitly warns against. First, a normal serum ammonia level absolutely does not rule out overt HE. Checking daily ammonia levels to guide your treatment decisions is actively discouraged. Treat the patient, treat the symptoms, don't treat the ammonia number. Second, if a patient with known cirrhosis comes in confused, routine brain imaging like a CT scan is not suggested unless your physical exam uncovers new onset focal neurologic deficits. Save your hospital's resources and trust your clinical assessment.
Section 5. Outpatient Care and Prevention. Securing the Transition.
Because managing HE definitely doesn't end at hospital discharge. Outpatient vigilance is the only way you break that devastating cycle of hospital readmissions. The ACG provides an outpatient flowchart that is basically your ultimate clinic companion. It structures exactly how to systematically address cognitive complaints in your cirrhosis patients. Before you even jump to cognitive testing for HE, the guidelines mandate that you screen for the 3 most common confounders first, which leads us right into the vital screening tools you need to use.
To use that flowchart properly, you have to actively screen for 3 specific conditions using validated tools that easily drop into your EMR. Use the Audit-C for alcohol use disorder, the Stop-Bang questionnaire for obstructive sleep apnea, and the MMSC or MoCA for underlying dementia or mild cognitive impairment. Think about it. A patient who is drinking heavily or a patient who stops breathing 50 times a night due to sleep apnea is going to have profound cognitive fuzziness. You absolutely must address these specific comorbidities before concluding their persistent mental fog is purely a hepatic issue that requires lifelong laxatives.
We're going to leave you with a final thought to reflect on today. Hepatic encephalopathy is a devastating, systemic disorder that traps patients in a holding pattern of suffering. As our diagnostic tools get sharper and our clinical pathways become more refined, when will the transplant system actually evolve to fully recognize the true burden of HE? How can we eventually align objective transplant scores with the subjective reality of our patients, ultimately saving them from that terrible limbo? Thank you so much for joining us for this explainer, and we hope this structured playbook really empowers your clinical practice going forward.